In the previous quick tip, we talked about filling a root canal access through a crown and also some other considerations. Today what I wanted to briefly mention is when I recommend to replace an actual crown following endodontic therapy rather than filling the access. Okay, so obviously you replace a crown if the crown breaks or is damaged somehow during the access preparation. However, that is a rare issue if you use a sharp round burr or a sharp diamond burr that is fresh and you use a very gentle pressure, lots of water, and treat the porcelain or the zirconia or the lithium disilicate as gently as possible. And then you won't break the crown during access preparation. It's fairly rare for that to happen. But when would you then replace the crown if it's intact after the access opening? Again, obviously if you open the crown and you also find frank decay underneath the crown, which would mean that you have a large carious lesion underneath the crown, then in those cases you really should remove the crown in order to remove all the decay before you even begin the root canal, because you know that the predictor of success in your case is going to be the complete removal of decay before the root canal therapy. Otherwise, if you do the root canal through the crown while decay is present and the access preparation in the underneath the crown, you're going to contaminate your field chronically while you're doing your instrumentation. So it's very important to remove the crown. Now, you would also remove the crowns that have poor open margins, or the margin is so open that you are going to have decay anyway, and you're going to compromise your irrigation because you're going to have leakage from the side of the crown. Those cases you should really recommend the removal of the crown prior to your root canal therapy. So keep in mind that defective crowns are likely be the cause and also the need for root canal therapy. Therefore, while you can do a root canal through the crown and save the crown, as we call it, you haven't really addressed the source, which is micro leakage. A more gray area obviously presents itself when you have a tooth that has a very good crown and everything is good. There's no signs of clinical or radiographic signs of an open margin, but the tooth requires a root canal. In those cases, I have a clinical rule in my practice that I use that I just wanted to share with you. What I do is, in the absence of any clear radiographic or clinical signs of a defective crown, or a bad restoration, what I would do is I would recommend the replacement of the crown if the crown is 5 years or older. If it's younger than 5 years, then I would not necessarily replace the crown following access preparation. Now, why do I do that? Well, although some pulpal damage can occur soon after crown cementation that can lead to necrosis, it's usually the older cases of necrosis which are inadvertently due to micro leakage. So this leakage is obviously invisible to the naked eye, and that's why we call it micro leakage, right? But even though microscopic, this leakage is the source of the bacteria that invades and kills the pulp, and therefore you should try to replace the crown in those types of cases. However, in a younger crown, it may not necessarily be due to micro leakage. It may have been trauma that occurred to the pulp during the core stage or during the crown cementation, or any of those things that could have possibly been the cause. So while the root canal addresses the symptoms, pulpal necrosis is not addressed until you address the source, which is leakage. Of course, I'm also very practical, and because I understand that the cost of these things and the new crown and replacing it is very exorbitant for some people, I always provide these as treatment options to the patient. And as long as the patient understands that continued micro leakage may potentially cause endodontic failure down the line, then I let them make the decision on their own and taking their chances based on what their priorities are. Part of our job is really educating our patients about their options and also the risk of each option versus making the decisions for them or on their behalf. After all, that's really the definition of informed consent, right? So I'm curious to hear about your clinical experience and also what are your recommendations to your patients. So please share your comments below this video, and in the meantime, let's save some teeth.